So these are the learning objectives. As I told you, I'll have the time to present you just morphological appearances of the lesions, of the agents, and these are the etiologies of most of the infections: bacterial, fungal, parasitic, and viral. And filling this slide, you can see here all the types. I'm going to start, I'm not going to show you all of them because of course they wouldn't have time. But here I start with the pyogenic bacteria and something about tuberculosis and syphilis. Before showing the bacteria, I'd like to tell you that most of the lesions we are going to see all these aspects. Sometimes they can occur, the same agent can cause more than one lesion, but meningitis, encephalitis, myelitis, they can be polio or leukoencephalitis, polio when they involve the gray matter, leuco when they involve the white matter. Some do not cause inflammation, encephalopathy and myelopathy, as I'm going to show you. But most of them cause space-occupying lesions or pseudotumors, which can be abscesses, granulomatous lesions, non-granulomatous, usually necrotizing lesions, cystic lesions, and calcified lesions. Some cause vasculitis and therefore infarct and hemorrhage, and some cause congenital infections, therefore malformations. As I said, one single agent can present with various morphological patterns. For instance, tuberculosis may present with meningitis, with tuberculoma, and tuberculous abscess. Toxoplasmosis as encephalitis, or usually with the space-occupying lesion. Cryptococcosis with meningitis, but also with tumor, cryptococcoma. And according to the host, for instance, cryptococcosis will appear as meningitis when the patient is immunodeficient. But if he is immunocompetent, it can be a cryptococcoma. Toxoplasmosis, cerebral toxoplasmosis only occurs in immunodeficient patients. Tuberculosis, if the patient is immunodeficient, it can occur as an abscess, and I'll go to show you some cases. And they all can be acute, subacute, chronic, or post-infections. We can see sometimes the pyogenic, for instance, we can see in the acute form, subacute, and chronic infection. The others I'm going to show you during the presentation. So these are meningitis. These are very hyperacute meningitis caused by Neisseria meningitis. This is gram-negative agent, and it is usually fatal. Is the Waterhouse-Friderichsen syndrome, and there isn't even no time to cause the exudate, the purulent exudates. Here are bacterial meningitis, where you can see already the purulent exudates, and both convexity and base of the brain are affected. Histologically, it is an acute infection with lots of polymorphonuclear neutrophils, but they can also go towards the brain and cause microabscess, where we can see masses of bacteria like here, even inside the vessel like here. And but also subacute and chronic stages can occur. The patients who sometimes are not well treated, or it persists for a longer period. So we can see this whitish or opaque surface of the brain. And this, of course, there is sometimes some fibrosis which obstructs the flow, the CSF flow, and can cause one of the complications, which is hydrocephalus. But also in the acute stage, we can see ventriculitis. And this is a case of ventriculitis and hydrocephalus. This is an acute meningitis, where you can see here there is pus inside the third ventricle, here inside the fourth ventricle, in the hydrocephalus. This is a very congested vein. These veins are very congested. They can be thrombosed, and also venous infarct can occur as a complication of meningitis. And also abscesses, those micro abscesses can increase and cause large abscess by contiguity. Although most of the abscesses come from hematogenic origin, as you see here, they are usually round or oval and with a smooth surface. So these are the bacterial abscesses coming from hematogenic origin. But we also receive specimens with abscesses. So these are two cases we had here some time ago. And sometimes we can see the pus inside. And also the wall is already hard, fibrotic, because most of these cases are already in the subacute or chronic phase. They are organized abscesses. Histologically, the acute abscess, we can see the pus inside here. And the wall usually have lots of newly formed vessels. This is the granulation tissue. From here, we can have progressive fibrosis. Fibroblasts proliferate from the vessel wall, and we can have fibrosis. This is one of the few situations in which there is fibrosis in the brain. And there is the edematous and gliotic brain on the left. The pyogenic contents, as I said, is full of neutrophils, the polymorphonuclear neutrophils. Here we are already getting to the wall where newly formed vessels are formed. And if we do a gram staining, in this case, they were gram-positive cocci, like here and here. It's not very good for the resolution, but they are blue, or dark blue. Less frequent abscess, I saw here bacterial abscess. We saw last year, 2 years ago and last year. This was a postmortem. When we cut the brain, it was an HIV positive patient. There were these abscesses here and also in the pons. And this was a surgical specimen. We received these fragments of tissue fresh and then fixed. And when we saw the histology, it was an abscess with lots of mononuclear and some polymorphonuclears as well. There was a tendency to form granuloma, but they were not typical granulomas. They were maybe a giant cell, but not the typical giant cells as we're going to see later. And when we did the stainings, the special stainings, they were positive with the silver grocots. They were filaments like this, and also positive with gram, but they were filaments. So the appearances are those of nocardia, which is, I saw just these two cases, which was in the last 2 years. Tuberculosis is still a major health problem, as you know, and it presents as meningitis, tuberculoma, or tuberculous abscess. Tuberculous meningitis is usually a basal meningitis. So the inflammation is in the base of the brain. The meninges are usually thick, whitish, grayish. And here we see after section of another case. And they can obstruct the flow, of course, the CSF flow, and also cause vasculitis. For this reason, sometimes we can have infarcts in the region which should be irrigated by these vessels. Histologically, there are granulomas here. There are lots of epithelioid cells. Here is a giant cell, a Langhans giant cell. There are mononuclear cells, and here a vasculitis. This was taken from an old slide, so the focus is not very good. But the lumen is almost closed. Sometimes we see the giant cells, the granuloma, in the walls. So these are responsible for infarcts. The other presentation is tuberculoma. So this is a space-occupying lesion. There is a confluence of small tumors here, small lesions. Here we see the brain after the autopsy. There is necrosis in the middle here. But this necrosis is here on the left. It's not pus, it's not a purulent exudate. This is caseous necrosis. And going to the right, there are the granulomas here and here, lots of mononuclear cells. Looking closer in another case, we see the granulomas here, several granulomas, mononuclear cells, and the Langhans giant cell here. And the other form, which occurs only when the patient is immunodeficient, this is a surgical specimen we had last year. And we see that there is this exudate, which looks like pus. But when we saw histology, there were some neutrophils, but the appearance was mainly a caseous necrosis. The inflammation, which is here, does not form granulomas. So it was rich in mononuclear cells, but no granulomas. Looking closer, we see here the necrosis at the center on the left. Here's the inflammation, no granulomas. And in these cases, when the patient is immunodeficient, it does not form granuloma. There is no reaction for this. And in this case, the bacilli proliferate a lot. So in this case, we can find in this area here, lots of acid-fast bacilli. Syphilis is not very common, although sometimes we are seeing nowadays. It's not very easy to confirm the diagnosis. For surgical neuropathology, we need to know the goma, which is a space-occupying lesion. This is a case we had with this necrotic center here. It's not purulent exudate. Looks like caseous necrosis, but on the left there were no granulomas. There was a dense mononuclear infiltrate with a tendency to surround vessels, like here. And apart from, in addition to lymphocytes, there were lots of plasma cells, like here on the right. So when we see this, we have to think of syphilis. The stain, the special stain is not very easy to make. We have it. It's a silver impregnation, the Wharton stereo. Sometimes we find, but since it also stains the axons, which which in this case are fragmented here, they may be mistaken by small axons. So there is a immunohistochemistry, which we did in this case, but it was negative. But the patient we suggested serology, the VDRL, and it was positive. So this was a goma by syphilis. Now going to fungal infection, I'm going to talk about these ones. Cryptococcosis, as I said, meningitis is the form which is presented in immunodeficient patients. It can be at the base, and at the convexity is usually white, slippery, gelatinous because of the appearance of the contents of the fungus. So we can have two cases here. And histologically, sometimes there is inflammation, but usually in very immunodeficient patients, we don't see too much inflammation. There are some mononuclear cells. There may be even giant cells. But here we can see inside these spaces here, these empty spaces, which is full of these yeasts. So these are the cryptococci. They have a capsule, which can be seen here even with the HNE, but with the PAS, they are very well seen here. But they can also present as cryptococcoma. So this was as a surgical specimen we had a few years ago. We can see that there are some nodules, white, yellowish nodules. Histologically, there was, here is the brain, and here there are granulomas, we can see very easily here. But then going closer, we can see that there are giant cells and lots of fungi, which are here stained with the PAS. So this is a cryptococcoma. This is what I'm going to show. What I'm going to show you now is that not all parenchymal lesions by cryptococci are cryptococcomas. In fact, these are extension of the meningitis, which is going toward the here's the meningitis with full of cryptococci, and they follow the vessel walls, the space, the Vikov-Ruban space, and they go towards the brain, and they can cause these cystic areas. And here's a very severe case which I had some years ago, many years ago, in fact. It was an AIDS patient. We can see these holes, all these small holes in the basal ganglia. In the histology, we see usually a vessel in the middle, and around we can see the fungi. And this was a very extreme case. When we see this, we can think of cryptococcoma, but no, this patient was an AIDS patient. He had meningitis, and this was a colonization of the fungi inside the brain and inside the cerebellum here. This is not the same case, but just to illustrate that in these cases, we see lots and lots of fungi. I take the opportunity to show that the multiplication of Cryptococcus is made by single budding. So we can see here one large one and a small budding here, another one here, another one here. So this is the way they multiply. Another one is histoplasmosis. This was also an AIDS case many years ago, more than 20 years ago. And when we saw the histology, when we saw the macroscopic appearance of the fresh brain, I managed to make a smear here this time, and I could find these multinucleated giant cells full of small yeasts, and these are all histoplasma. It usually causes a basal meningitis like tuberculosis, and for this reason, the vessels which get inside here, they can also be obstructed. And in this case, when I cut the brain after fixation, I found this infarct in the base of the brain and also in the basal ganglia. Now, a case we had recently here, I think 2 or 3 years ago, it was operated as a clinoid tumor in a 47-year-old HIV positive man. When you look at the histology, there was inflammation, fibrosis here on the left, and this basophilic area here that getting closer, we saw inflammation, some neutrophils, polymorphonuclear cells, and here in this basophilic area, it was full of hypha, large non-septate and branching hypha, which are typical of mucormycosis. So these are with HNE and with PAS. This occurs in immunodeficient patients, very common in diabetic patients as well, in this the base of the brain, close to the olfactory region. Now the last mycosis I'm going to show is one that we find in Brazil. It's caused by South American Paracoccidioides brasiliensis is the name of the fungus, and the disease is called paracoccidioidomycosis or South American blastomycosis. It's found in soil and vegetation, so in areas where there is agriculture and farms, we can find this. Preferential sites are lungs, also oral and nasal mucosa, and lymph nodes, but the brain can also be affected. And when I worked in a region in São Paulo, close to Minas, in the interior of the country, I managed to see a lot of cases. So I'll show you 3 cases, 3 autopsies. This is one where this is space-occupying lesion, which looks like a tuberculoma, is seen here in the base of the brain. Here it's seen in the pons, at the dorsal part of the pons, and here in high cervical spinal cord. Here you can see here. Here is the 4th ventricle. This is the medulla, and this tumor, which, in fact, they did a biopsy some weeks before he died. It didn't reach the lesion. It was below or above. We couldn't make the diagnosis, but then when we saw, it's not the same case, but just to show that this, again, a lesion that had extensive necrosis in the center, and then inflammation, and there are granulomas, which you can see here. Lots of giant cells. In this case, they contain the yeasts inside, here and here. They can also be free, seen towards the necrosis here. With the PAS, we can see them very easily. And with the silver impregnation, we can also see, and I used to take the opportunity to show that multiplication in this case is made by multiple buddings, as you see here, and as you see here, and also here. Just now an unusual presentation of fungal infection. This was this year, in the beginning of the year, a 50-year-old man with a frontal cerebral tumor. When I saw the histology, it was there was extensive fibrosis. In fact, most of the specimen was pink, like here on the left, but we could find a small microabscess, and in the middle of some of them, we could find this structure that we can see with the PAS. They were, it's not very easy, but we could recognize some hypha and yeasts. So in fact, these are packed fungi in a situation that is called mycetoma. Mycetoma can also be caused by other, including bacteria, actinomycosis, but in these cases, it was caused by lots of fungi. Now the parasitic infection, let's talk first about protozoa. Toxoplasmosis, which is the most frequent, only occurs, as I said, in immunodeficient patients. It can be acquired or congenital, and most of the acquired presentations are space-occupying lesions. So this is what we saw in the beginning of AIDS, 1986. This is autopsies from that period with the extensive necrotizing lesion usually taken in involving the basal ganglia, but also in other regions. It's not the same case, but the imaging is like this. But then in the late 90s and beginning of 2000, here in 2001, when patients had already been treated and also treated with heart, so but if they died, we could see this scar, this cavity cystic appearance, and here too of treated toxoplasmosis. And histologically, sometimes we can still see inflammation, lots of macrophages, but in other situations we don't see any reaction with what we call the burnout lesion. The problem is that nowadays, this was this last month, I think, 2021, a patient operated with a space-occupying lesion like this, no information about immunodeficiency. When we saw the slides, there was inflammation, vasculitis, like here, edema, necrosis. In that case, we have to look for the toxoplasma, and we found below here the cyst and some free forms. So this is toxoplasmosis. We went back to the surgeons and asked to look for immunodeficiency. In fact, the patient had AIDS and did not know. And we are seeing this case recently here. This is another one. This was a needle biopsy. It was a fortunate biopsy because in this biopsy we could see everything. We saw the vasculitis, we saw the inflammation, we saw necrosis. Here's the vasculitis, and we have always to make the differential diagnosis of lymphoma. But in addition to the inflammation and necrosis, we had to look for for toxoplasma. This was an HIV positive patient. And this is the typical finding of some free forms. They are spread here. The necrosis is usually a dirty necrosis, and necrosis also can involve, not the same case, but may involve the vessel which is inflamed and can be can have thrombosis in the center. So the important information here is that this is not a granulomatous lesion. So if we found granuloma, we can discard toxoplasmosis. And this is another recent case. We were fortunate to find in this smear the free forms of toxoplasmosis. And here in this another case, in the paraffin section, we could see the free forms. If you don't find, or even if you find it but are in doubt if it is really toxoplasmosis, we can make the diagnosis with H&E. But there is immunohistochemistry. This we did in the smear. This is in the paraffin section. Is this just a node electron microscopy picture which I showed of which I'm showing here of toxoplasmosis, but of toxoplasma, sorry. But as I said, encephalitis can also occur, but this is very rare. I think I saw 2 cases. One was an autopsy, and this was a recent case in a patient, in an 8-year-old patient. He had undergone kidney transplant, so he was immunodeficient, and there was an encephalitis. They did a biopsy, and we could find the cyst here with very little inflammation. This is not the same case, but just to show you that when there is, in cases of encephalitis, it's very common to find microglial nodules. As you know, they are usually found in viral infections, but toxoplasmosis is one of the situations in which there are microglial nodules too. The congenital one, as you know, causes extensive necrotic lesion. This brain has been destroyed by necrosis and calcification. The brain, the cerebellum, and the spinal cord here. The fetus is immunodeficient. Is immunodeficient too. That's why if toxoplasma gets there, it's like in the brain, those necrotizing lesions. The only thing is that it destroys the whole brain, as you can see here. Well, trypanosomiasis, I'm not showing African because I haven't never seen, but when I worked in that area that I'm going to show where it is, which is endemic for trypanosomiasis, for Chagas disease, which usually does not cause cerebral involvement, usually causes autonomic system involvement with megaviscera, megacolon, megaesophagus, cardiomegaly. But in the when the patient is immunodeficient, this happened here in 1994. It was an endemic. It is an endemic area, and there were lots of patients with AIDS, and it causes an extensive necrotic lesion with intense parasitism. So I was cutting this brain here. And this is the region here. Here I'm here in Rio. I was working here. This is the limit between São Paulo and Minas. So in this area is endemic for Chagas. Nowadays we don't see the acute forms anymore, but there are many people who are living there with old, elderly people who had Chagas disease. And this was one case. He had Chagas disease, and then he got AIDS. And he died. When I examined this brain, I saw this lesion that I never saw anything like this. Toxoplasmosis is usually not like this. And histology, it was full of parasites. So in these are protozoa. They are inside the cells like toxoplasma. The thing is that there were a lot, and they are slightly larger than toxoplasma. And since that, there they had the immunohistochemistry for Trypanosoma cruzi, we could confirm that this was the reactivated form of Trypanosomiasis. I saw 2 cases. Malaria also is a lesion that a disease that I don't have experience. It occurs, the cerebral malaria, only in the severe form of the infection, caused by Plasmodium falciparum. I'm not going to talk about this. You can read, otherwise it will be long. But just to tell you that it is in the Amazon region that there is malaria, and also in the west of the country. But since I was working in this region here, a patient who went to this area, he's got malaria, and he came back to be treated here, and he died. So I managed to examine his brain. And this is the typical form of cerebral malaria, the one with several petechia, like here. And I'm just showing quickly the histology. This usually close to the petechia. This is an old slide. We can see capillaries with the trophozoites inside, and there is a pigment here. So this is, I cannot talk about pathogenesis, but just to illustrate one case of cerebral malaria. Well, amoebiasis is some years, the old people managed to see just 1 or 2 cases of entamoeba histolytica. They cause intestinal infection, and in those cases, cerebral abscess are found. But they are very rare nowadays. This is amoeba here. But what we have seen more recently, I mean more than 40 years ago, are the free-living amoebas. And they can cause primary amoebic meningoencephalitis, granulomatous amoebic encephalitis. Cerebral involvement is maybe fatal, usually fatal, particularly here. Here, the patient does not need to be immunodeficient, can be young and immunocompetent, and they usually get it with contaminated water in swimming pools, for instance. The parasite gets into the nose, and then the cribriform plate and go to the base of the brain. But granulomatous amoebic encephalitis, I saw it can be caused by Acanthamoeba, Balamutium mandrillarius, and others. I managed to see one case in the 80s. I think this was in 88. It was the period when we were seeing lots of AIDS cases. When I saw this, I thought this could be toxoplasmosis, but then no, it was full of amoeba. And also more recently, I got this example from a colleague, an ex-resident who lives in the northeast of the country. So he sent me these images here of in fact, there are several foci of hemorrhagic softening in the cerebellum and here. So this is granulomatous amoebic encephalitis because there are giant cells. Granulomas are not very well formed, but there are lots of giant cells, necrosis, inflammation. The amoebas are usually, they can be free, but they tend to surround vessels. Here there is a vasculitis. With the PAS, they can be seen. With the HNE, we have to be aware of this because they are pale. They can be mistaken by macrophages, but they stain with GIMSA, with PAS, and occasionally they are in the cystic form, like here. Among the amines, I'll talk about cystic sarcosis. Cystic sarcosis, neurocystic sarcosis is caused when the humans are the intermediate host after ingesting the ova of Taenia solium, which is the worm. Cystic cerullosis, therefore, is the larval form of Taenia solium. I'm not talking about pathogens, just to tell you, we don't get it when we eat pork meat. We get it when we eat the ova, which are usually in badly washed vegetables. And I saw some, here in this region, I saw some surgical specimens like this. Here we have the scolex, the head of the larva, which is still viable here, and usually degenerates. And here are other specimens in which you have it is degenerated, so we just have this irregular cavity here. But these are extreme cases in autopsies that I saw in that region many years ago. So you can see here lots and lots of cysts. And this is the histology of the scolex, the head of the larva here. It tends to be like the head of the Taenia solium. There are the hooklets, the ventosa here. And the cyst is surrounding here. So most of the times we just see the cyst. So this is the wall of the cyst. It has a surface undulated. Here it is already degenerated. And here there are some stages. Sometimes we can see viable like this undulated surface. There are some nuclei and these small cavities here, but they get degenerated. And when they degenerate, here is completely degenerated. We have to think of it when you see this undulated surface here. But when they degenerate, they inflame. So they may be giant cells here or just lymphocytes. Like here, this is a cyst, a degenerated cyst. And here are lymphocytes. The neuroimaging is very typical with this ring enhancement vision. And they calcify. Here are calcified cysticerci, here are again, and this is the histology. And this is when they are located in large cavities, like here, and here, and here. These are called the racemose cysticerci. And in this situation, they do not have the scolex. Strongyloiditis is just one example I saw, just one. This was also in the 90s. The patient had strongyloidosis, which is an intestinal infection, but he was immunosuppressed. So there was massive intestinal growth of worms, and they spread to the circulation, and the patient had symptoms of meningitis. The CSF examination showed the worm here, but the patient died, and I managed to find just one here in the subarachnoid place. So this is arachnoid, and here is the worm. Schistosomiasis is uncommon. Schistosomiasis can be caused by three species here. The American is the Mansoni. Neuroschistosomiasis is uncommon and overreach the CNS by retrograde passage through the portal mesenteric and pelvic vein in valvulus vertebral venous plexus of Batson. Thoracic and lower spinal cord are common locations. I saw one case. I have seen in the cerebellum, but which is also a common location. But this was a case I examined from a patient who died with a myelopathy. When we look at the spinal cord, this is the thoracic spinal cord. And the second row here, sorry, this is taken from an old Lenten slide, it's out of focus. But this second row is the transverse section of the thoracic spinal cord, which, as you know, is usually thin, but is thick as the cervical and the lumbar. And histologically it was full of ova inside giant cells. And they have a typical spine here. Is the spine, depending on the site of the spine, the location of the spine, it can be one of the species. The Mansoni is a lateral spine. And going now to the viral infections, I'm going to talk just about a few ones here. Arbovirosis, as you know, they have limited geographical distribution due to the necessity of climatic conditions for the insects to live. This is are called like this because these are arthropod-borne viruses. So, and one of them is dengue that we have here in Brazil. It's caused by a flavivirus transmitted by the mosquitoes Aedes aegypti. Usually causes benign infection, but they may be hemorrhagic. And I examined 5 brains in the 1980s, end of 1980s, during an epidemic, during epidemics, and 5 patients died. 3 of them had normal brain, but 1 had an encephalitis. So there was lymphocytic inflammation around the vessels and some hemorrhage. And the other had a post-infectious perivenous demyelination. In fact, he had dengue, he was well, and 3 or 4 weeks afterwards, he got a neurological disease. He died of this. It was a perivenous demyelination. Zika, as you know, disappeared more recently in Brazil. Again, a flavivirus. The infection, human infection, also is a mild fever, arthralgia, headache, myalgia. But what happened was that in 2015, lots of cases of microcephaly appeared in the second semester of 2015. And some died, and I managed to examine some cases. Usually there is calcification in the brain, and this is one of the cases I examined. This is the one hemisphere. We can see that it is a smooth brain, and another one is there is calcification here. It's a microcephalic brain, very small. The large ventricle is in fact an ex vacuo ventriculomegaly. But the problem is that some cases, there was not microcephaly. In fact, the size of the head was normal or even large. And in these cases, there was obstructive hydrocephalus. Due to the calcification here in the midbrain, the aqueduct was closed. There was a huge hydrocephalus. But in fact, the brain was lost. There was a thin layer of brain because it had gone. If it was not for the obstruction, it would be a microcephalic brain. And the pons, we can see that the basal pons was not present because there were no descending fibers to form the base of the pons. Another observation, well, I saw lots of observations, just to show you this last one, that there is also migration disturbances. The virus affects the progenitor cells at the germinal matrix. Those which are left, they migrate, but everything has been damaged. So there is this over migration towards the pia, which is responsible for this cobblestone appearance of this lissencephalic brain. Also, the spinal cord is usually thin, but it's thin because those root ganglia are normal. It is thin because there are no descending motor axons. Therefore, the lateral cortical spinal tract is absent. Now, it's still with virus. I have this is an abscess I had. I think 4 years ago. It was operated like an abscess, but the strange was there were lots of small nodules here. Looking closer, they were microglial nodules, which are not usual for abscess, for pyogenic abscess. And looking closer, there were cytomegalovirus here, which could be confirmed with immunohistochemistry. Which is it's the first time I see an abscess like this with cytomegalovirus. As you know, cytomegalovirus can cause congenital infection, can cause microcephaly, and also in AIDS patients, they cause ventriculitis, they cause myeloradiculitis. But like this is the first time I saw. And this is also an uncommon infection, viral infection, was a 34-year-old man who coursed with progressive dementia and myoclonus. The clinical hypothesis was prion disease. The autopsy was made with all the care for prion diseases. And in fact, we saw spongiosis, we saw gliosis, there was neuronal loss, but then we saw inflammation. And this is not seen in prion disease. Looking closer and looking for the cause of this, we could find the intranuclear inclusions here. So this case was a subacute post-infection, subacute sclerosing panencephalitis, sorry, SSP, post-measles. We went back to the history and this patient had measles. Another viral infection, this is an opportunistic infection, is that caused by polyomavirus GSA virus. It infects oligodendrocytes, which cannot maintain and form myelin, so there is demyelination. There are lots of macrophages because of the demyelination. There are atypical astrocytes. They are also atypical because of virus. But we also find inclusions in oligodendrocytes. These are mitosis in astrocytes. Lots of macrophages. And going to the end, I have here retrovirus. I'm not talking about HIV. I also have a lot of material, but just showing one case of HTLV1 that causes myelopathy, the tropical spastic paraparesis. In fact, there is not there is hardly an inflammation, but there is this affection of descending and ascending tracts of the spinal cord. Here's the degeneration of descending cortical spinal tract and the generation of ascending spinal tract, sensory. Just one the case of, which is node case, which I also took from Lenten slides. You see that just the anterior horns of this spinal cord are damaged. So this is a poliomyelitis. Polio, this because it's just the gray matter. Histologically, there is a lesion here, inflammation in the softening of this anterior horn. Getting closer, we just see one remaining motor neurons because all the others have gone through and there is neuronophagia. And the last one, I saw 2 or 3 cases of rabies. The patients had bitten by bats in the north of Brazil, but the material came to me and I examined this case. So just to show the typical intracytoplasmic eosinophilic inclusion in the Purkinje cells, which are typical, which are in fact the Negri bodies. So in this presentation, you managed to see, you could see all these presentations of the infections, which I'm not going to repeat here. And these are the references were containing many of the illustrations included in this presentation. Thank you very much for your attention. Sorry for the delay.
Okay, do you want to share the digital slide that you had?
Yes. I forgot. Just a moment. I have to share here first. Can you see it?
Yes,
yep, we can see it.
Yep.
Okay. Just put it in full here. Yes, so I suppose you have seen, this is an inflamed brain here. There are cuffings of lymphocytes here, edema, gliosis, necrosis here, no inflammation, no granuloma. So with this information, I think you know already what we have to look for. We have to look for toxoplasma. So sometimes it's not easy, but here, for instance, if I go closer, I don't know if you saw it, but here, this is one of the illustration, the slides I showed. So this is
we can see it. It's beautiful. Yes, yeah. You can see it. Yes.
And here, let's see if I find here. Yes, here. I also showed. Here there are some free forms here. Look here. And here a cyst. It's not so nice as that one. So this is a cerebral toxoplasmosis. It can be easy, but can be difficult, and sometimes we have to look for them. That's it. Okay?
If it's okay, we'll go ahead with Q&A. Those pictures in the presentation were just absolutely spectacular. Thank you. And so at this time, we'd like to move to Q&A. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner. Once you've asked your question, please remute to avoid background noise. Okay, so I'm going to read a question I can see here in the chat box. I cannot see the name. I have an autopsy case of a basilar meningitis with caseous necrosis, multinucleated giant cells, and endarteritis obliterans. Based on the pathology, my first 5 guesses would be TB, and my next 3 guesses would be syphilis. Extensive workup for both during life was negative. All bug stains are negative: bacteria, fungi, AFB, Warth, and Starry. Do you have any suggestions as to what to look for?
No, I think you did the right thing. This is what we need to think. The only observation I can make is that sometimes we don't find the acid-fast bacilli, but even so, it is tuberculosis. So I think one has to still insist in treating tuberculosis, because otherwise I don't think of other possibility.
Okay. That question was from John Donahue. And I'm going to go ahead with the next question from Saroja Elangovan. Have you seen Aspergillus infection, especially in HIV patients?
Yes. In fact, I didn't talk about Aspergillus because of lack of time. I saw, but it's not necessarily, the patient does not necessarily be immunodeficient, as you know. Just to complete now, since you're talking about Aspergillosis, is also a large IFA, but there is a tendency to invade the vessel and course with hemorrhage. And I saw in both cases, not many cases, I saw both in immunodeficient and immunocompetent patients.
Okay. And from Maria Beatriz Lopez, thanks for your lecture, excellent. What is your experience with anti-mycobacterial immunohistochemistry versus Nielsen or fights?
In fact, I don't have the immunohistochemistry. I do both. I do both either Nielsen or fight. I prefer Nielsen. But when there is, we can see in both, in fact. But I usually ask Nielsen first.
Okay. And then next from William McDonald, spectacular images, a world-class collection. Thank you. What is the role, if any, of 16S RNA sequencing in your practice?
No, I don't. Sorry, can you repeat, please?
What is the role, if any, of 16S RNA sequencing in your practice?
No, I don't have this experience, sorry.
Okay. And then the next from Saroja Elangovan, very thorough lecture, thanks. And then I don't see any more questions, but if it's okay, I would like to ask one. So with the toxoplasmosis in the HIV patients, we used to see a lot, and I really think it went down with the antiretrovirals. We still would sometimes see a few, but is there a direct treatment for toxoplasmosis in the brain?
Yes, there is. This is the reason why we should really make this diagnosis. And here in Brazil, what's happened is that there was that period of AIDS, then we didn't see anymore. But what is happening here, I don't know if it is everywhere or not, is that people are not, many people are not aware anymore of AIDS. Sometimes they have it and they don't know, and they present for the first time with a lesion that is operated. In here, at least we saw 2 or 3 cases in which they didn't think of AIDS, they didn't know that he had AIDS, and it presents already with this infection. So it's
okay.
not difficult to find, and it's important to find it, to treat it with sulfadoxazole or zinc and others.
Okay. And then I think there's a couple more from Saroja Elangovan. Have you seen pseudoaneurysm in circle of Willis in AIDS patients?
No, I haven't. Have never seen.
Okay. Okay, if anyone else has questions, you can go ahead and unmute yourself.
Okay, so
I just have one more question come in. Hang on just a second here.
So there's one more question. I had an autopsy of an 8-year-old girl who had meningitis at the age of 2. She had a fibrous meningitis. We couldn't find a cause of death, but the brain was absolutely glued to the meninges with some degree of hydrocephalus. Have you found similar cases?
Well, this can happen. In fact, they didn't find the etiology. They didn't find the etiology of the meningitis. Could be bacterial meningitis, which became chronic, and this can happen. And even if now we won't find the cause anymore, but could easily be a bacterial meningitis, which became chronic. This can happen.
I think that question was from Lee Ang. She says, how do you distinguish histologically?
Histological. In these cases, there will be fibrosis, there will be little inflammation, I think. I'm not sure if I got the correct.
Yeah, you can unmute yourself. Oh, someone wrote, how do you distinguish, I'm sorry, I think it's a different question. How do you distinguish histologically amoeba versus macrophages?
Well, it's a question of experience. The macrophages, the nuclei are very sharp. We can see those small, round, sharp nucleus. The cytoplasm, I'm talking about the foamy macrophage. The cytoplasm has microvacuoles because it's full of, usually in brain, they are full of fat. So, but I think that they are. It of course is much easier to identify the macrophage than the amoeba. But when you think of the amoeba, you have to look for it, and it will be different from macrophage. And if you have doubt, of course, you have to do a immunostaining, a CD68, for instance. But it's not difficult, I think. But if you are not thinking of amoeba, you can go pass by and not see it. Okay.
Okay. I don't see any more questions.
Okay, great. Well, thank you again, everyone, for joining us for today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation, which will be entered into the chat box momentarily. Completion helps ensure accurate reporting to the accreditation board. The PowerPoint slides and recording will be posted to the AANP website in the next week. Thank you again to Dr. Chimelli for an excellent presentation, and this concludes the session for today.
Thank you very much to all of you and those who make the questions.
Yeah, thank you. It was fantastic.
Thank you.